In this section, we will discuss autoimmunity. In this section of the lecture, we will discuss autoimmunity. So autoimmunity is another one of these headings that kind of falls under failures of the immune system. Again, autoimmunity, it may be more advantageous to you to think of this not as a failure, but as an inappropriate response. In autoimmunity, you don't have lack of immune system. What you have is the immune system, again, responding to, in this case, autoantigens or self-proteins. So if you can remember that and keep that in mind, it will help you to kind of picture what's going on in autoimmunity. So there's a broad spectrum of autoimmune diseases. They can be very organ-specific, ranging all the way to systemic. A lot of that has to do with the reason behind the autoimmunity, what cells are involved, or what class of hypersensitivity they may or may not fall under. And we can see very specific, such as the thymic diseases like Graves' disease, all the way through to very systemic, like SLE. So before we get into specific diseases, let's talk about how autoimmunity happens. Remember, we have in our immune system various tolerance mechanisms that are set up in order to prevent this type of thing from happening. And this is kind of a review slide. We've touched all of these points in other sections of the lecture, but just to review, as far as T cells go, remember we have central and peripheral tolerance. Central tolerance refers to what happens in the thymus, with the positive selection and the negative selection. So remember, in the positive selection, we're eliminating T cells that don't recognize self-MHC, and in the negative selection, that's where we eliminate the T cells that bind to MHC too tightly or may be responding to self-antigens. So we should get rid of, or we hope to get rid of, all of those autoreactive T cells in here in central tolerance before we even release them in the periphery. Despite the fact that the thymus is fairly efficient in doing this, there are autoreactive T cells that make it through the thymus and get out into the environment. So we have further tolerance mechanisms that have been put in place to prevent them peripherally from being activated. One of them is immune privilege. We have certain tissue sites, such as the eyes and the testes, that do not allow the immune system to come in. This will prevent any types of autoreactivity from going on there in these specific sites. Other things that are peripheral co-stimulation requirements, we've talked about energy and the need for that second co-stimulatory signal. We've also talked about regulatory T cells being able to downregulate the immune response. So these are all T cell tolerance mechanisms. As far as B cells go, we have clonal deletion, and this happens in the bone marrow during B cell maturation. And if there are self-antigens that these B cells will bind to, if the B cell is specific for that self-antigen, it can cause cross-linking of the surface receptors, and that will induce apoptosis during B cell maturation. Another type of tolerance for B cells is called clonal anergy. B cells that bind to antigen in the absence of co-stimulatory signals from T cells can also become anergic. So despite all of these tolerance mechanisms, we still have people that get these autoimmune diseases. These occur because of breakdown in these mechanisms, and the immune system doesn't properly distinguish self from non-self. There's a high association for many of these diseases with certain MHC haplotypes, indicating that the way in which MHC processes and presents and sees certain peptides has something to do with causing autoimmunity in these people. However, that's not to say that this is a Mendelian type of inheritance, and if you have B27, then you will automatically have ankylosing spondylitis, for example. There are several other theories as to why autoimmune diseases occur. Besides being genetic, there has to be some other type of environmental insult, environmental factor, something else coming into play. So some of these theories include the release of sequestered antigens. We talked about immune privileged sites, so perhaps through trauma or injury, antigens from these sequestered sites become exposed to the immune system and you get an autoimmune response. Another idea is the idea of molecular mimicry, and this has been shown in certain diseases, for example, Campylobacter jejuni and Guillain-Barré syndrome, where Campylobacter has an antigen that's very similar to certain antigens that are found in your nervous system. And when the immune system starts to respond to these C. jejuni antigens, they're close enough that there's cross-reactivity with antigens in your nervous system. Other types of ideas, polyclonal B cell activation, EBV is famous for this, where it can activate B cells that are not specific for EBV antigens. And one of those B cells that may be activated may be an autoreactive B cell. Another theory is that self-antigens are displayed in an inflammatory context. We know that self-antigens are constantly being cycled through the MHC molecules, and if there happens to be inflammatory milieu for some other reason, you could incite an autoreactive immune response. However the case, etiologies of most of these autoimmune responses are really unknown, really poorly characterized at this point, but we do know that this is an immune type mechanism. So here we have certain disease associations. I've highlighted and read some of the more important ones that you may want to remember or keep in mind for the boards. Ankylosing spondylitis has a very high association with HLA-B27, as does psoriasis and IBD. Primary hemochromatosis has a very strong association with A3, and narcolepsy with DR2 or DQ1. Notice that most of the other disease associations are with either DQ or DR alleles. So if you have to guess, go with a DQ or a DR, probably a DR. So here's how you might see an autoimmune type question on the boards. A 27-year-old man complains of lower back pain that wakes him up at night. He says the pain usually dissipates after he has been up and moving for a few hours. He says that his father used to have the same back troubles. X-ray analysis reveals fusion of the L2 and L3 vertebrae. Which of the following MHC haplotypes is most commonly associated with this disease? Is it A, A4, B, B27, C, C5, D, DR4, or E, DQ2? And the answer here is B, B27. This is ankylosing spondylitis, right? We have a young male, lower back pain, family history, L2 and L3 fusion. That's ankylosing spondylitis, B27. So here's some examples of autoimmune disease. In this picture, very common symptoms associated with Graves' disease, right? You see the exophthalmos. You also see the goiter in the neck. Common findings for somebody with Graves' disease. So in Graves' disease, it's a very interesting autoimmune disease in the fact that these antibodies are not destructive, they're stimulatory. So here we have a B cell that makes antibodies that will bind to the TSH receptor on thyroid cells, but instead of destroying the thyroid cells or mediating their destruction, they actually stimulate the thyroid cells. So these antibodies will stimulate thyroid cell survival, and that leads to more thyroid cells than you would normally have. It prevents regular turnover, and you get hyperthyroidism and hence the symptoms of Graves' disease. Now contrast that with Hashimoto's thyroiditis, shown here, where you have the typical response of what you would expect or kind of more associate with an autoimmune disease. This can either be mediated through B cells or through CTLs. You get autoreactive cells that will bind to or destroy or cause the destruction of thyroid cells. As you destroy the thyroid cells, then you get hypothyroid, and those are where the symptoms for Hashimoto's comes from. So again, Graves' disease, stimulatory hyperthyroidism, Hashimoto's thyroiditis, destruction, hypothyroidism. Another example of an autoimmune disease is pernicious anemia. Here again, this is antibody mediated with antibodies binding to a specific type of tissue. So this would be a type 2 hypersensitivity, right? Pernicious anemia is characterized by defective red blood cell maturation due to a malabsorption of vitamin B12 that kind of results in this megaloblastic anemia that you see. So the B12 is blocked because of antibodies that can be either associating with intrinsic factor or parietal cells. Remember that intrinsic factor in normal processes will bind to B12, and then once this intrinsic factor B12 conjugate gets into the small intestine, it is then transported into the blood. In the case of pernicious anemia, we have antibodies to the intrinsic factor that can prevent the binding of the intrinsic factor to the B12, and the B12 will just go through undigested, will go through without being absorbed, and therefore we don't have it for proper red blood cell maturation. In another type of pernicious anemia, we have antibodies against the parietal cells in the stomach, which is the source of the intrinsic factor. So in that case, the parietal cells get killed and no intrinsic factor is produced. The result is the same: malabsorption of vitamin B12, megaloblastic anemia. With myasthenia gravis, this clinically presents as muscle weakness and fatigue. A patient will come in and they will have the inability to move or effectively move proximal muscles. It tends to get worse throughout the day. They get really tired and fatigued. And what the immunologic factor going on with myasthenia gravis is is faulty neuromuscular signal transmission. These patients have antibodies to the acetylcholine receptors. These antibodies bind to acetylcholine receptors, prevent the acetylcholine from transmitting the signal from the neuron to the muscle, and you get muscle weakness, you get discoordination. A lot of times where you see this discoordination is in the eyes and in the eyelids, the small muscles, and these patients will come in with the inability to fully retract their eyelids when they look up, as you can see here in the picture. So what can we do for these people? Well, as with any immune disease or autoimmune disease, you could try to give them steroids, but those have a lot of side effects. One of the more unique aspects of the disease here allows us to, instead of getting rid of the autoimmune disease, we outcompete the antibodies. We give these people anticholinesterase inhibitors, and what that does is allow the acetylcholine to stay longer in the synapse, and it can outcompete the antibodies for those receptors. And in so doing, we can get the signal transmission. Another example of autoimmune disease is Wegener's granulomatosis. This one's kind of going a little bit further. We have a little bit more variety of tissues being destroyed. Again, here we have type 2 hypersensitivity, but instead of just one organ, now we're involving two. We have renal involvement and pulmonary involvement. So these patients will come in with renal problems, they come in with recurrent upper respiratory tract involvement, and also lung involvement. So in the renal involvement, what you tend to see is crescentic rapidly progressive glomerulonephritis. In the upper respiratory tract, these patients will come in with a variety of different symptoms. They can vary from sinus pain and drainage to purulent bloody nasal discharge, all the way to nasal ulceration and nasal septal perforation, which may or may not include the palate. Pulmonary findings can range from asymptomatic to cough and hemoptysis. One of the diagnostics that we use to diagnose Wegener's granulomatosis is the presence of C-ANCA antibody. So here we see this immunofluorescence stain here. This is immunofluorescence staining for C-ANCA, and that is diagnostic for Wegener's granulomatosis. In Goodpasture syndrome, similar to Wegener's, we get affected lungs and affected kidneys. Some of the differences here, this is young adult men, okay? And what we see here, linear deposits of IgG and complement along the alveolar and glomerular basement membranes. This is the type 2 hypersensitivity where we have antibodies binding directly to type 4 collagen that is seen, for example, in these alveolar and glomerular basement membranes. And you can see here on the immunofluorescence staining, you can tell that this is the type 2 hypersensitivity because it looks like on this staining somebody took a pencil and kind of traced that basement membrane. It's very tight. It's because that staining is staining the antibodies that are binding directly to that tissue, so it's almost like it's outlining that tissue. If you see something like that, pencil thin, like somebody traced a tissue, that's type 2 hypersensitivity on immunofluorescence. Multiple sclerosis, another type of autoimmune disease, characterized by mononuclear infiltrates with demyelination of the CNS. The immune response that you see is actually to a protein, or one of several proteins found in myelin. One of the more abundant proteins is the myelin basic protein. You also see in these patients increased IgG in the spinal fluid. This is an oligoclonal response, or you might see it called oligoclonal bands on the CSF. So this indicates that there's some B-cell involvement. However, by and large, multiple sclerosis is thought of as being caused by T cells. So this has some T cell involvement, some B cell involvement. Symptomatically, it's characterized by motor weakness, ataxia, impaired vision, bladder dysfunction, paresthesias, with the B cells of the macrophage, or whatever it is that's causing the problem, chewing on myelin. The neurons that they're destroying will be affected, and therefore, depending on which neurons are being upset, you get different symptomatology. We also diagnosed MS along with the oligoclonal bands by looking at MRI patterns, and you see gadolinium-enhancing lesions as being characteristic for patients with MS. Type 1 diabetes, this is kind of well known. This diabetic picture, the inability to synthesize insulin, you get hyperglycemia, they get polydipsia, polyuria, classic diabetes. Type 1 diabetes is characterized by one of several different features. It could be mediated by CD8 T cells, and in that case you get CTL destruction of the beta cells of the islets of Langerhans. It could be antibody mediated with anti-islet cell antibodies or even anti-insulin antibodies, all leading to this insulin deficiency, hyperglycemic state. You can see on pathology islets that are infiltrated with B and T cells, as you can see here. All of those little purple circles, remember on H and E staining, if you get the purple circles, those are lymphocytes surrounding an islet here in the pancreas. Rheumatoid arthritis, this is inflammation of the joints, another one that's very well known, very well understood. This is a type 3 hypersensitivity where we get immune complexes that are formed, and that's actually the rheumatoid factor that you look for is antibodies binding to other antibodies. They form these immune complexes. They then get shuffled off into synovial joint spaces where neutrophils will come in, try to break them down, and in the process of trying to break them down, they destroy cartilage, they destroy bone, and you get the characteristic features, swan neck deformities, things like that that are characteristic of rheumatoid arthritis, as shown here in the picture. Scleroderma and crest are kind of similar, both similar diseases along the same spectrum. More common in women, both of them. Scleroderma has been associated with anti-SCL70 antibodies. They get excessive fibrosis and edema of the skin. So you can see here a couple of pictures. On the upper picture, you see the tightness around the lips and the cheeks. That's characteristic of that scleroderma, that fibrosis and tightening of the skin. You also see sclerodactyly, as shown in the bottom picture, where the fingers curl up and the patients are unable to fully extend their fingers. That's a marker of scleroderma. Now, apart from just the skin features, you get visceral organ involvement, and that's what makes scleroderma more serious, more with higher morbidity and mortality than what you may see, for example, with Crest syndrome. In the esophagus, you see dysphagia. In lungs, they get pulmonary fibrosis. In the heart, you see CHF and arrhythmias caused by fibrosis. And in the kidneys, you get chronic renal failure, again, because of the fibrosis. And it's the kidney damage that actually causes the highest mortality. 50% of the deaths are due to chronic renal failure. Now with Crest syndrome, this is more benign, more limited than scleroderma. Crest is an acronym. C is for calcinosis, or calcium deposits, as you can see. R is for Raynaud's syndrome. Remember, cold fingers, they turn color when they get cold. Esophageal dysmotility, sclerodactyly, which we've discussed, and then telangiectasia. So that's your Crest syndrome there. Systemic lupus erythematosus, this is primarily a disease of young women. In fact, the female to male ratio is 20:1, so really, really favored towards women. Multi-organ involvement, this is a systemic disease. They get constitutional symptoms like malaise, fever, lethargy, and weight loss. They get the characteristic butterfly rash like you see in the picture. You might also see this called a malar rash on the boards, or if you see something that says that a rash spares the nasolabial folds, that's another way in which this rash is described. These patients get kidney failure. They can have CNS manifestation. They also have arthritis and arteritis. Lots of different involvement in lots of different tissues. The immunologic features that you're going to look for, the screening test is an ANA, not quite as specific as the anti-DNA or anti-SM type of tests, but a good screening test. So if they're ANA positive, then you look for the more specific test, the anti-dsDNA or the anti-SM. Also, another immunologic feature is that patients with SLE have decreased levels of complement. Remember, we discussed this in a prior section, that when you have chronic inflammation, chronic immune complex formation, the complement is continually trying to break down those immune complexes, and because of that, you have decreased levels. Here we see a picture of a wolf. This is kind of where systemic lupus erythematosus got its name. They say that the malar rash that's characteristic of lupus is similar to the facial markings that you see on wolves, hence systemic lupus erythematosus. Here we have an immunofluorescence staining, and I want you to contrast this with what you saw with, say, Goodpasture syndrome. Remember, in Goodpasture syndrome, you had that pencil-thin line. Well, here you have more of a fuzzy type of picture. It looks like somebody took a crayon and kind of colored in. This is because they're staining those immune complexes. It's not such staining antibodies that are binding directly to tissue like you would see in type 2. This is type 3. This is immune complex, and with staining those immune complexes that are filling up spaces, it looks more like this fuzzy or this crayon type of texture. So pencils, type 2, crayons, type 3. So here we have a vignette. A 32-year-old woman visits a dermatologist because of a persistent facial rash. Physical examination demonstrates an erythematous rash without blistering or ulceration, involving both cheeks and her nose. The nasolabial folds are relatively spared. The dermatologist also notes scattered erythematous firm maculopapular lesions elsewhere on the woman's face and on exposed areas of the neck, upper chest, and elbows. Careful examination of the scalp demonstrates a few areas of focal alopecia. On questioning, the woman reports that she has had the rash more or less continuously for about 6 months, and that it gets much worse when she is exposed to sunlight. So a lot of things going on here. We have a woman coming in, persistent rash, nasolabial fold sparing, other maculopapular lesions. This rash tends to get worse when she's exposed to sunlight. Which of the following autoimmune diseases would most likely produce this patient's skin problems? Is this dermatomyositis, progressive systemic sclerosis, rheumatoid arthritis, Sjogren's syndrome, or systemic lupus erythematosus? And the answer is E. The classic facial characteristics kind of promote you to this answer choice, SLE. Continuing on with the vignette, the dermatologist biopsies the rash and sends the sample for pathologic examination. The biopsy shows liquefactive degeneration of the basal layer of the epidermis accompanied by edema at the dermal junction. Immunofluorescence microscopy would most likely demonstrate which of the following: A. Granular deposition of immunoglobulin and complement along the dermo-epidermal junction. B. Granular deposits of IgA selectively localized to the tips of the dermal papillae. C. Lacy network of IgG deposits in the intracellular spaces lining the keratinocytes. D. Linear basement membrane depositions of immunoglobulin and complement. Or E. No deposits of Ig or complement. The answer here is A. Again, this is lupus, so you're thinking type 3. So you know it's not a linear deposit. You can get rid of D. You know that you're not going to have no deposits, so you can get rid of E. Granular deposits of IgA, we know that SLE is more of an IgG type picture, so you can get rid of B. And then between A and C, A is the one that includes both immunoglobulin and complement. Also, the fact that it's at the dermal-epidermal junction all indicate SLE. Continuing on, the patient is referred to an internal medicine specialist for further evaluation. The initial immunologic workup demonstrates a high titer positive ANA test, which is followed by the demonstration of other more specific antibodies. High titers of which of the following are considered to be highly specific for this patient's disease? A. Anti-dsDNA, B. Anti-Jo1, C. Anti-SSA, D. Anti-SSB, or E. Anti-U1RNP. The answer here is A. Anti-dsDNA, highly specific for SLE. With modern therapeutic management, the 10-year survival for patients with SLE in most developed countries is now approximately which of the following? Is it A. less than 5%, B. 20%, C. 50%, D. 80%, or E. more than 95%? This we haven't covered in the lectures. The answer is E. more than 95%. We have very good control and patient management now that allows good 10-year survival rates for patients with lupus. So here we have some of those autoantibody and disease associations. A lot of these have good hints that will help you to remember them. For example, anti-SCL, that's scleroderma. Anti-centromere, that starts with C, that's crest, also starts with C. Anti-SSA or SSB, that's Sjogren's syndrome, SS. So there's a few clues. Remember the anti-double-stranded DNA and anti-SM are associated with lupus. Antihistone is actually associated with a drug-induced form of lupus. Anti-U1 or U2 are associated with mixed connective tissue diseases, and anti-Jo1 associated with polymyositis and dermatomyositis. This concludes our discussion on autoimmunity. In the next section, we will cover immunodeficiencies.